So let's get going. I'm Pat. I'm a trauma and acute care surgeon at the Medical College of Wisconsin. I'm really excited about this session we have and really want to thank the Health Economics Committee for supporting this and the AAST. And we have a great lineup of speakers of a topic that's really quite near and dear to my heart and theirs as well, I think. So before I introduce them, I just want to note that the AAST no longer offers CME credits for this. If they do become available in the future, you'll get an email in order to claim those. So without further ado, so we have three speakers today. I'm going to give a brief intro, but I do want to mention who they are. So Dr. Jennifer Hartwells is going to start. She's at the University of Kansas. She's the service line director of EGS there. Dr. Napolitano is the division chief at Michigan. And Dr. Buhavac is about to be new faculty at the University of Wisconsin-Madison. So this is kind of why this topic is important and why it's gained a lot of attention recently, which is a good thing, in that there's a real challenge in our specialty, not just acute care and trauma, but general surgery and surgery as a whole. This was a very recent article that gained a lot of media attention, and this really frames a lot of our discussion. And specific to our specialty, this has been studied kind of within the last decade, 15 years or so, that our specialty, even compared to other surgeons, has decreased career satisfaction, higher level burnout, decreased mental quality of life, and increased depression. We're number one among these 14 specialties, which is, I don't think, something to be proud of. And, there's a clear relationship between those facts and our job. Our job is different at times than other surgical specialties. And we have to kind of reconcile that with the results I just put up there. So we're going to explore this relationship and how we might impact this today. And so just to frame kind of the demand of our specialty, our patients are 1/5 of the hospital and about a quarter of the costs. As I said, burnout is high, the highest among surgical specialties. Turnover in our specialty is high. And there's really no universal definition of full-time employment in our specialty. If you ask me, and this is all I talk about at conferences, feel free to find me at any conference. This is all I'll talk about. And I'll ask you about your job and how much you work and how much I think you should work. And I think it's 204 shifts a year. That's a full-time job, in my opinion. And I'm happy to expand on that later on. And I can't wait to hear the opinions of our speakers today. And so the goal of today is to figure out how we might move the needle on some of those facts. So, our job is demanding. How can we as surgeons and how can our leaders impact us and our health and our wellness? And we're going to get a perspective of a surgeon who is about to start a new job in a couple of weeks in Madison. And then we're going to get a division chief's perspective, and specifically on how to staff a division and how to work with administration to figure out what's right and how to right size a division. And then we're going to have a robust question and answer period. And I encourage you to really, as they come up, type questions in the chat. And at the end, we're going to go through those questions, and you're welcome to direct them at a specific person or just to the group as a whole, and we'll figure it out from there. So without further ado, I'm going to pass this off to Dr. Hartwell.
Thanks, Dr. Murphy. All right. Ensuring my slides are looking okay?
Yeah.
All right, great. So thanks a lot for the opportunity to come speak here. I think this is going to be a really great talk. I'm really grateful for it. I have no particular disclosures. I'm going to throw a ton of information at you, so I'm happy to make my slides available if anyone is interested at the end. But as surgeon scientists, I feel like we have to address this with the data and then go from there, not just from feelings. So this is a pretty robust and recent study from JAMA of 60 magnet hospitals. And you can see they're involved over 5,000 physicians. Burnout in nurses was higher than physicians. We were at about 32% in this survey. Less than 10% of respondents described their workplace as joyful, which is really sad. Both physicians and nurses rated management interventions to improve care delivery as more important to their mental health and well-being than interventions directed at improving clinicians' mental health. So I think that's very telling for all of the wellness initiatives that are happening these days. And improving nursing staffing was the number one thing. This is a really busy slide, but just to summarize, the blue box at the top of this is what nurses identified as their top concern for well-being, which is improving staffing. And the yellow boxes highlight the top concerns for physicians, which is reducing clinician time spent in documentation, improving the usability of the EHR, and reducing the emphasis on clinical productivity targets. So again, none of these are, if only I had more pizza parties. These are very concrete things that are identified that are important to us. The findings, the summary I thought was very telling. The clinicians lack confidence in management to resolve patient care problems and rated improvements in staffing and work environment as more important than institutional wellness and resilience programs. Again, as surgeon scientists, the Medscape data, which Dr. Murphy showed in another slide earlier about burnout. The top concern of physicians is too many bureaucratic tasks and EHR issues. None of it is, I need more pizza parties. So I want to go through a quick list of things that I think are salient things that are just real life things that we take home with us. And I'm going to try to offer some real life actionable things that we can do to mitigate these. So obviously as surgeons, we have ergonomic stressors. I, for one, as I get older, am noticing this is a significant issue, more so than it was for me 20 years ago. We do a lot of walking when we're on at work. We have back-to-back meetings and lots of patients. We work early mornings and late evenings, so we come home fatigued. So we actually just started an ergonomics education initiative, which has been very well received at KU for this very reason, because we come home in pain. And so we're seeking ways to improve that while we're at work. One of the things that I've learned day after day to make most important is to clear my calendar for post-call days to the best of my ability. And maybe even post-call days. The older I get, the post-call day is actually really stressful. And learning to outsource the things that are physically demanding at home. As attending physicians, we do tend to have the resources to outsource. Somebody can cut the lawn, somebody can come clean my home, and that's reserves my physical capabilities for my family. Mentally, I think I had a medical student tell me a couple of weeks ago after his first day in the ICU, he said, wow, you just make so many little decisions, one after another. And I'm like, yeah, you're right. That's what critical care is making a million micro decisions a day. It's mentally exhausting. We also take home a lot and worry about our difficult cases. I'm sure we've all had an experience of waking up at 3 a.m. worried about the patient we just operated on. And so the best thing I can tell you is sleep. You have to sleep. There comes a point in time where working more is actually counterproductive, and choosing to just shut it down and get some sleep is by far the best thing that we can do for ourselves mentally. Exercise, remember 3 10-minute exercise periods are the same as 30 minutes. One thing that I'm trying to get better and better at is pre-making decisions. So on Sunday night, my husband and I sit down and we decide what we're doing for dinner this week, so that I'm not coming home at 6 o'clock and going, I don't know what's for dinner. And I'll address that again here in another second. Most of us have the luxury of just wearing scrubs every day, which is fantastic. It's one of the reasons I'm a trauma surgeon. But any decision that we can make ahead of time helps us when we're mentally exhausted, that we're not persevering over it. And finally, emotional exhaustion. We tend to have difficult patient interactions, breaking bad news, dealing with difficult colleagues, workplace harassment, you name it. We come home emotionally exhausted too. So one thing that we need to focus more on is giving ourselves permission to have all of our emotions. I tell my residents that all the time when they think they have to be tough. I'm like, no, actually you don't. That's the worst thing you can do. You need to give yourself permission to have a range of all of the emotions. Setting aside time for therapy. There are certain times in our careers that therapy is really needed, and we need to give ourselves permission to clear our calendar to do that. And I'm also getting better about coming home and having frank discussions with my husband and kids about how much I have left in my tank, how busy was my day, how much energy physically, mentally, emotionally I have, so that there's clear expectations about what work life or home life will be. So, what are some other actual actionable things that we can do besides the just be more resilient stuff that we hear all the time? So, this is a really fascinating article. I put the link down there at the bottom. You can just Google AMA debunking the myths. I found this super fascinating that there's actually a bunch of things that we do at work that we don't actually have to do, that are not, that we have, like, over time, we thought that we had to do them, or that we thought that there were rules about these things, and it's actually not true. It's become a myth. So actually, the Joint Commission does not regulate what if we can have our bottle of water or a snack at the nurse's station. It's the state, what it's state level occupational and safety hazards and risks and rules. So there's a lot of things that we think we're being regulated on, which are actually we're not. And so I would encourage anybody to take a look at this. And this is a starting point for helping to speak to your health system and leadership about what are we actually doing that we think we have to do, but we don't have to do, that we can take out of our workflow. Also, very interesting data about electronic health record. So I've often said in my role as wellness is that we're not going to talk about the electronic health record because I can't fix it. It's a beast that's beyond my control. So we just have to suck it up and get over it. But there's some pretty interesting data that shows that if we spend 1 to 2 hours in specific training to get personalized setup of our EHR, using our dot phrases and templates and favors appropriately, like asking for 1 hour of dedicated at the elbow training is as helpful in terms of satisfaction as 20 hours of training. So the data shows there's a clear breakpoint. If we invest 1 hour, if I give 1 hour of my time, I'm going to have a better experience with my electronic health record. And hopefully that will reduce my frustration because I feel like I've taken the time to set it up to work for me. Again, not a panacea, but investing in my own wellness with an hour of help. And I'll kind of wrap things up with some very practical things that I think we can do. One is setting boundaries. It's an interesting thing. I say a lot of what I know about life I learned from my kids and my husband. And one of the things about being a parent is kids won't tell you that they need boundaries, but they need and want boundaries. Like, people actually want to know where the line is because they want to know when they're reaching the point of stepping over it. And so this actually occurs with all of us. We all need to know where the boundaries are. And so I make some pretty hard and fast boundaries about meetings, no evening or weekend meetings, no expectation of replying to email after 5 p.m. Some of you have seen the disclaimer I have at the bottom of my email that says, I respond when I have time. I expect you to do the same. You don't have to respond to this. I might be that I'm sending an email at 2 a.m. because I'm on call and I have time. That's not what I expect of you. When I was a chief resident, I had or a junior resident, I had a chief resident say, listen, in surgery, you need to have a rule with your family that you make no important decisions when you're post-call. I violated that rule and I found myself with a puppy. I found myself with ice cream for dinner one night. But I think it's a good rule of thumb. We don't make good sound decisions when we're mentally, physically exhausted. And so we do have a rule in our household that we don't make important decisions when I'm post-call. So we don't buy houses or cars or decide on relationships or having extra kids or anything like that when I'm post-call. Some very practical things that I do for myself. We have a family calendar. It's a Google calendar shared by everyone in our family. Since the time our kids were in young grade school, we said, if your sports practices are not on the calendar, you don't have a ride. So you put your own things on the calendar. When I go to conferences, my flights go on the calendar, so my husband knows when to expect me. So again, setting clear expectations. I'm just throwing out some things that we do in my family that makes it smoother at home. Is we have one of those Amazon Echo things, and I realize people don't love those because they think that the government's listening, and maybe they are, but I don't have much to hide. And so we do our shopping lists on here. So if you're the last person to drink the milk, then it's your job to say, Alexa, add milk to my shopping list. And then when you go to the grocery store, it's on your phone. Whoever goes to the grocery has the shopping list. So silly things like that. We also have a rule in our house: when you turn 12, you do your own laundry. If you wake up when you're 13 years old and you don't have clean underwear or socks, that's on you. So again, setting the expectations that everybody is a part of this family. Something we try to do, it's getting harder and harder, but to have family dinners. And this is where we sit down and have that communication. And I think the biggest thing we can all do is over communicate at home so that we all have expectations and have the opportunity for my kids to say, Mom, you missed whatever, or I need you to know about, or Mom, can you set this up for me? And so there's communication. And that happens a lot of times for us at the dinner table. I don't know about you all, but those of you who have kids, sometimes the first thing out of my son's mouth when he wakes up in the morning is what's for dinner. And so sometimes I have an answer for him, and other times the answer is every man for himself. So we'll text each other, what's for dinner, EMFH, which means open the fridge, find what you want. When they were little, I used to tell the kids it was tapas. They thought that was great. What really, it's eating leftovers. Another thing I did for myself is I turned off notifications on my phone so that every time I open my phone, there's no little red bubbles by any of my icons. And this gives me a sense of not feeling distracted when I'm at home. And I think that helps me be more present with my family. So best thing I ever did for myself is turn off those dumb red bubbles. Another thing I do for myself is to be hyper organized. So every time I have an event, I make a little note card and I give myself a checklist of everything I need to do to prepare for that event so that I'm not like showing up at AAST and realizing I forgot to book my hotel, or that I forgot to claim my CME, or that I forgot to prepare my slides. And then I check things off as I accomplish them. So I'm going to leave you with some action items. We all love checklists. As you can see, sometimes I put things on my list just to check them off. So one of the things we can do for our system, not just individually, but check out the things that we're doing that we don't have to be doing, that we think we have to do, and eliminate those things from our lives. Advocate for safe staffing. Dr. Murphy can tell you all about that. This means following our own research. We are surgeon scientists, and when we have the data that says we are overworking, then we can take that data to our health system and say, we are overworking, this is the data. Invest personal time in improving your EHR experience, inventory your life, what needs immediate action to be taken off your plate to help improve your work-life integration. Sometimes this looks like handing things off, or resigning from something, or reducing your expectations, setting clear boundaries, and then draw them larger. Whatever you think your boundaries are, make them a little bigger, create some white space in your day. Block your calendar for personal care. I put every time I get my hair and nails done, it's on my work calendar. I don't care who knows if I'm going to get my hair done. That's my time, and I'm blocking it off. And no, it's not available for a meeting. Make your to-do list every day and estimate how much time it will take you to complete it, and know that it will take you 100%, 120% of your estimate. So my recommendation is make your list and then just cross off 2 things because you're not going to get to them. So this just helps me and level set with my family that when they say, Mom, I need you to go to the grocery and pick up the dry cleaning and all these things, I say, okay, now eliminate 2 because I know I can't do all of that. Don't say yes to everything. And the most important advice I ever got from my therapist was stop hustling for your worth. Take care of yourself. Stop with the rat race. You can't win it. Take care of yourself and your family. I ask myself, is it worth it? My kids have never seen my resume or my CV. They don't even know what it is. They're never going to ask for it. And I've never seen anybody's CV on their tombstone. So be mindful of what matters to you. I think that's the best way to help prioritize family and work. And that's what I have.
Thank you, Dr. Hartwell. That was fantastic. Dr. Buhavac.
Okay.
Feel free to type stuff in the chat if you guys have questions as they come up.
Well, first of all, thank you very much to Dr. Murphy for inviting me to be part of this panel, and thank you to Dr. Hartwell. I wish I had listened to that talk 5 years ago when I was embarking on this journey. Incredibly useful to all of us in the early phase of our career. So I've been asked to talk about the surgeon's perspective on trying to find the right position in today's job market. And let me see here. Why won't you go? Oh, there we go. So just a little bit of background about why I might or might not be the right person to discuss this, I spent 4 years at Texas Tech. I was very fortunate to get a job down in Northwest Texas, and had a great experience doing lots of different things, wearing lots of different hats. The job changed for me on a pretty routine basis, and I was fortunate enough to have the ability to look for positions elsewhere and do things. So I spent a few months earlier this year interviewing at about 7 or 8 places, trying to find something that was more in line with the advice that Dr. Hartwell gave in the talk prior to mine. And I, unlike the first time around where I was just thrilled to have a job, when I was initially interviewing out of training, I interviewed at about 3 places, and I was just thrilled that somebody was going to offer me a job. I didn't really ask any questions. I wasn't too concerned about what my schedule would look like or what I would do. I really wanted to work and do this thing that I've dedicated myself to, and I didn't really think about any of the things that might come along with it. So a couple of things, echoing on, and I promise none of us have seen each other's slides prior to this. So if there are some common themes, I think it just speaks to the fact that we're all aware and we're all experiencing the same thing. You can't do everything. I think that if you have it in mind that you're going to be a triple threat and you're going to be able to walk in every single lane and do everything, that is incredibly challenging. And if that is something that you are going to dedicate yourself to, it's going to come with a lot of sacrifices and a lot of time, and it may not be exactly what you would like it to be. So spend a little bit of time figuring out what matters to you, both personally and professionally, and try to figure out how to integrate those things, because it's very difficult to get in a lane and then try and jump out of it, or change paths. It's possible, but if you've dedicated a lot of time to things, it takes a lot of extra work to try and wear all those different hats. Some of the best advice that I received several years ago at a relatively small conference was spend your first 5 years becoming a great surgeon. I am still within my first 5 years of practice, and everybody keeps telling me, those skills, they start declining eventually. And if you haven't really spent a little bit of time polishing them and making sure that you can do it, it's hard to get them later on. But if you know that you're not going to be a technical wizard, and that a huge part of your professional career isn't necessarily going to be the patient care, then maybe that doesn't apply to you. And the one lesson that I really wish that I had known, that Dr. Hartwell also mentioned, is learning how to say no. Lots of people are going to ask you for lots of things, especially, we in the specialty of trauma and acute care tend to be hard workers and go-getters. So you just go out there, you don't make a lot of fuss. We know it's a very difficult job. We just saw a lot of data from both Dr. Murphy and Dr. Hartwell about how challenging this job is. A lot of us just put our heads down and get on with that, and we keep being asked to do more and more. It's okay to say no and say, everything that I can do, I'm already doing. So when I had a second go at this and I was looking for jobs, I actually spent a little bit of time trying to figure out how am I going to find something that actually fits me and what I want to do with my career. So as you can all tell, I'm not a Texas native. I am originally from Eastern Europe. I trained in the United Kingdom. Location has never been important to me. I wanted to get some distance between my parents and I to get my freedom, and I have accomplished that. And I have, moved around in the United States over the last 12 years. So if location is important, put it high up on your list and make some compromises around that. I don't think all of us need to be academic. I think a lot of the really important work that happens in trauma and acute care surgery is happening in community hospitals and level 2s and 3s, rural access hospitals, where patients are first landing, and perhaps even that we should be focusing more on that than our big level 1 centers, so that we can get the boots on the ground and take really good care of patients. Dr. Murphy mentioned, what is a normal FTE? What is normal amount of work? I don't know the answer to that question. When I was in charge of trying to come up with that, we just kind of continued what was tradition here in Texas, and the FTE was 14 shifts in a month, which is probably a little bit too much, but you have to make do with what you have. Another thing that I have encountered over the last 5 years is figuring out which bucket you might want to put yourself into. If you're going to be at a large volume center that's academic, it might be unreasonable to think that you're going to be able to do trauma and EGS and ICU and jump between all those things and still deliver very good patient care. So figuring out what kind of acute care surgeon might be very important to you. Perhaps having some sort of elective practice and cutting down on EGS and ICU might be something that you need to do. If you're going to take a position, don't just think about the position that you're taking, think about all the potential positions that you might have there in the future. Are you going to be in charge of a particular service line? Are you going to be in charge of residents, education? Are you going to be on the bureaucratic side with the hospital working on different things? Is that something that is important to you? Will you have that opportunity there? And of course, not that it should be last on that list, but to me, it was always the thing that I thought about the least, is compensation. How much am I going to make? Am I going to be able to give myself and my family a reasonable quality of life? I recognize that I have done no heavy lifting there, and that these are all the questions that everybody asks themselves when they're looking at jobs, or that I hope that they would. So what did I actually do that was different the first time around to what I did this time around in terms of finding the answer to some of those questions? How do I actually know that when I interview with somebody and I present myself to them and they present themselves to me, that we're actually on the same page? And some of the heavy lifting that I think needs to happen is you need to talk to residents. You need to find out how the people on the lowest level of the pyramid are being treated, because I think it speaks to the culture of an institution if the people that are doing the most work are treated just as well as the people that are at the very top. You're finding some place that is going to be able to support you in your endeavors. Talk to past employees, make sure you've had a discussion with all the staff there, make sure it's okay. Find out, why did they leave? Is there, have those difficult conversations, because you want to make sure that you're going into this with your eyes wide open. Discuss turnover. Are people retiring? How long have they been here? Why did they move on to new places? Things like that. Examine track record. I have always, although I wouldn't say I have been for the last 5 years, I've always wanted to be an academic surgeon, and that involves publishing. So if you're going to go to an institution that is going to invest in your academic career, and they say, well, we've got biostatisticians, we can offer you all these things, get on PubMed, have a look at who's publishing from that institution. How long have they been publishing? Have new faculty also published? Is it going to be a place where somebody who has not necessarily had an opportunity to grow their academic career, do they have a track record of growing people that can walk that line in academics? I am by no means the expert on compensation, and I hope that everybody here gets the reference about showing me or whoever it is the money. I foolishly, when I was interviewing 5 years ago for my first job, at every place that I interviewed, I told my prospective division chiefs, chairs, whoever it was, that I was in no way interested in compensation, and whatever they offered me that I would take. And I received the fantastic advice that I should never, ever, ever mention that sentence again, because nobody would take me seriously. So know your worth, as Dr. Hartwell said. Don't hustle for it. Know your worth. And that involves, again, going out and following the data. And I think an excellent place to start with that would be the MGMA data by region, figuring out what people of equivalent rank and experience are making. It's a Pandora's box when you start digging into these things, figuring out how compensation is calculated, what you're billing versus what is being collected. Are we looking at total RVUs versus work RVUs? How is productivity calculated? How important are things like academics and non-RVU related work taken account into compensation? Even though I didn't feel comfortable talking about it the first time around, these are all the questions that I was making sure that I was asking the second time around. If you are so inclined, you should ask about a sign-on bonus. I have to move from Texas to Wisconsin. I asked about a moving stipend and was granted a moving stipend. I know what I can do. I know what I can't do. I know roughly how much somebody in my position should be making, and that's what I advocated for at my prospective new position. And even though some of these conversations may be uncomfortable and you may feel like you're not in a position to have these discussions, I think that if we are going to get away from everything that both Dr. Hartwell and Dr. Murphy had mentioned about how hard this job is and the sacrifices that we all have to make, we have to get more comfortable in pushing back the boundaries and saying, well, we're not cardiothoracic surgeons, we're not vascular surgeons, but we do a lot of work. And some of us have to wear those hats because as trauma surgeons, you're going to be operating in the chest. You're going to be doing vascular stuff. You're going to be working a lot more than a lot of other medical specialties. The hospital will become like a second home to you. So invest in yourself and invest the time into having all these conversations so that you can find the best fit for you, because happiness matters a lot more than all the other things. And this is an excellent way to get at least a step closer to that happiness. I am notoriously bad at, I would say I am the poster child for the opposite of wellness. I have done way more work than I would encourage anybody to do over the start of their career. I'm incredibly grateful for everything that I have had the opportunity to do and all the interesting operations and everything that I have got to experience. But ultimately, I think that it requires too much of you, and that if you plan on having a long career, taking a deep breath and realizing that you have a lifetime to get to where you want to be is more important than trying to squeeze every little ounce out every little second. So as I was going through this journey of figuring out where I want my next job to be, it was very important for me to figure out exactly where I wanted to end up and then plan backwards and say, okay, well, my goal is to be here in 30 years. What are the steps that I need to take to get there? And there's no reason why it needs to take 5 years. I would rather do it slowly and well and it take 30 years than have it take 5 years and burn out and not be around to enjoy any of it. Something that I think hopefully Dr. Napolitano is going to talk about, and we'll have some questions about, because I'll ask her about it, is trying to find that balance between how do I give the institution, how do I give the team what it wants, while still walking that fine line between making sure that I'm making some progress and doing the things that are good for me. And with that, that's all I have. And thank you so much.
Thank you. Thanks for that. That was very personal, and really appreciate that. Our next speaker is going to cap off our speakers today and talk about the division chief's perspective. And I'm very excited to kind of hear maybe not the other side, but a different perspective on some of these challenges.
Hi, everyone. Thanks again, Pat and the team, for allowing me to participate here. I'm going to put us in show, hopefully. Does that look like that works?
That's perfect.
Great. So first, it's so refreshing to hear open and honest opinions about what we've all done and what we think this next generation maybe should do and should consider as they look at their careers in acute care surgery. So I'm here to give a little bit of a different perspective and would love to hear people's opinions. We have been hiring here at the University of Michigan in acute care surgery for quite some time. And I put on this slide, the significant challenges that we've had locally here, which I'm sure are similar to many other challenges. Building the ACS team, how to figure out how many surgeons to hire. I'll show you a little bit about what happened here. Expectations for ACS faculty, particularly as we're hiring new ACS surgical faculty. And then we have those that have been hired really in a different era and a different time with maybe a lot more clinical responsibilities. How do we figure that out? Academic versus clinical goals. We're pretty good here at the University of Michigan bringing up academic and scientific surgeons. Maybe we're not as good in terms of bringing up clinical surgeons, with great excellence. And how do we establish these different phenotypes within an acute care surgery division and respect them all? And then non-clinical expectations that we all have, some of which Jennifer went through: administration, research, education, academics. Those are all significant challenges. So I'm going to go one by one. Building the ACS team. This is really the first step. And the first step is really to define your service lines in your institution, and then the leadership roles that you have at your institution that you need faculty. And we really find it really important to combine the two, a leadership role in addition to the service as an ACS faculty in general. And then in addition, because again, we're focused on academics and research, we have to, sort of roll that in as well. And I have a list of our leadership roles here, but many of them are funded and many are unfunded. As we are reviewing many of these, they probably should be funded and should have focused time for each individual role. And then here's our Michigan Medicine Acute Care Surgery service lines. We have two ACS services, ACS 1 and ACS 2, which cover both trauma and EGS, and they alternate daily responsibilities for new admissions. For surgical critical care, we have a SICU 20-bed, which includes coverage of VV ECMO, and a trauma burn ICU, which is 16 beds. And then we have a separate burn surgery service, and then we have ACS surgeons that do elective surgery. So based on these service lines, pretty much every day we have 5 ACS faculty, and we need all of our faculty to be certified in surgical critical care so that we can cross-cover each other. And again, if I'm busy in the OR, somebody else can go to a trauma activation, or if I'm at a trauma, somebody else can take care of an emergent EGS patient. So I'll briefly go through what happened here. I joined the University of Michigan in 2005. There was a separate trauma burn service with 6 faculty, as you see listed there. And Dr. Bartlett and Swaniker were the 2 faculty that attended in the surgical ICU. And pretty much a year after I arrived, we transitioned to the Division of Acute Care Surgery, covering trauma, burn, surgical critical care, and we took on all emergency general surgery. And that was a big load, a big clinical load. So we had a few faculty leave. Dr. Bartlett retired. we hired up. So we've been in the hiring process for quite a while, from 3 faculty to 10, and all were certified in surgical critical care except for our burn director. And as those 10 faculty now became the new division of acute care surgery at the University of Michigan with transition to this ACS model, we had very rapid clinical growth, and we also actually had rapid research growth. And so we continued to hire, and we hired 3 more faculty. And so now we're up to 13, and they're listed here. But of late, in the last 2 years, we've had a number of faculty leave for the reasons I listed in the upper right: promotion, personal illness, family issues, like we've described. You know, you have to go where your family is and where you have family support. Geographic moves, sometimes in order to be close to family, sometimes for a spouse that is undergoing education or clinical development. So again, another rash of hiring here at the University of Michigan for acute care surgery. But also I want to sort of pose it as it's such a great opportunity to hire. It's a lot of work. It's a lot of interviews. It's a lot of dinners. And we heard a little bit from Milos, you know, about how challenging that can be. But here are 2 of our, you know, recent recruits. Rajan on the left, who currently has been escalated to our new M-Plan director for the trauma burn ICU. And on the right, Stacy Aubrey, who's one of our education superstars. But what we identified as we've had these sort of rashes of hiring over the years, over the entire time that I've been here, it's challenging, and we recognize that as an academic medical center, we're really good at the research part, but research in ACS has changed. Really, most ACS faculty are now focusing on education and health services research, whereas in the past it was mostly translational and basic science research. We don't have many SCC and ACS fellows that are interested in that anymore. So we had to really make significant modifications to our ACS sort of hiring approach. And one of these that was very important to me as an old surgeon and an old faculty member is, what do we do when we have new hires? What do we do with the faculty that have been here for a while and really have you know, contributed a huge amount of clinical activity, clinical service time to our institution? So I'm showing you here 2 different ads. This is an ad that normally would have been, you know, 4 or 5 years ago. It's just an ad for an academic trauma and acute care surgeon. This is at the University of Massachusetts. It doesn't give you any information about clinical service time, research expectations, goals. All it does is give you information about the ACS division and the institution in general. Everything else was left to negotiation. And then we had the wonderful work of Dr. Pat Murphy, our leader today. And he did this great survey and review of division leaders and medical directors, and really reviewed that we should be reducing our, you know, 1 ACS FTE down to about 26 weeks of service per year. Again, based on institutions, but in general, 26 weeks per year. And then he did the wonderful follow-up study of young surgeons, young ACS surgeons within 5 years of training, and showed that they really desired even less than that, 24 clinical service weeks per year, 4 calls per month. Again, recognizing an important component of their well-being was reducing clinical service time. So contrast that ad that I just showed you a minute ago to now an ad that just came out a couple of weeks ago. This is from Penn State Hershey Medical Center. And they are very clear here. This is, again, a trauma center. They are offering clinical service coverage expectations of 15 12-hour shifts per month. So we've seen changes in ads really delineating what the clinical service time is. So as we began to undergo additional hiring, and based on what I've really seen over the last year or 2, we're rapidly moving towards a benchmark of 10 to 18 12-hour shifts per month, very much as Dr. Murphy said. I personally queried 16 US academic level 1 trauma centers as we were going through our hiring process in our division, and about a quarter are still a little old school and have not changed much. I think you heard a little bit of that. But most have transitioned to a specific number of 12-hour shifts, as you see listed there, 12 to 18, 10 to 18. Some have a number of clinical hours per year, as you see listed there, 1,600 clinical hours per year, and everything else is paid above that. The clinical expectation baseline is 1,600. And the goal is keeping the salary above the 50th percentile of AAMC. So when we saw this change over the last year or two, it really is similar and parallel to what happened in emergency medicine. In 2019, ACEP, the American College of Emergency Physicians in Emergency Medicine, really dictated that core faculty clinic hours should be limited to no more than 28 hours per week or 1344 hours per year, whichever is fewer. And that really went globally. This is now from Australia, where they even delineated how many weekends and night calls ED faculty should take. And so they are very similar to acute care surgeons in terms of providing shift work. But when we hire a new surgeon, for instance, here at the University of Michigan, and they come in with a markedly reduced clinical workload, what do I do with that individual who's doing 3 weeks and 2 weekends, and they were hired in that realm because it was a different era? Clearly, clinical service weeks, call shifts have reduced. Clearly, ACS faculty salaries have significantly increased. So some of our older faculty may be making less in salary. So it is really important that in this new era, we need transparency, we need to right size our entire faculty, and we need to really be committed to equitable faculty advancement and compensation. Next, we here have very different phenotypes. We have the research and academic ACS surgeon, and then we have the busy clinical ACS surgeon. So how do we deal with that? My motto really is to hire great people. And here is our list of, key quality and skills in ACS faculty. First of all, they have to be a great clinician, a great surgeon. They have to be a collaborative team leader. They have to be great educators. We're all focused on education here. And then for our scientists, they have to be motivated to scientific and research inquiry. And once you hire these great people, which we've been fortunate to do, extremely fortunate, you really have to support their unique development and their personal goals. And I think, we heard from Jennifer how important that was. We can't overwork them clinically. We have to help them achieve success. We've had some, really great metrics of being able to do this here. We provide a clinical mentor separate from a scientific mentor. We have these launch and boost teams. We really have great respect for all phenotypes in surgery. The researchers do have less clinical activity, but they have really high academic expectations, particularly in extramural funding and publications. And our motto really is that all phenotypes should be valued as part of the ACS team, and we have to be transparent in all ACS team expectations. And I would say, particularly in making the faculty clinical call schedule, really important. And then finally here, non-clinical expectations. ACS has a huge role in education at most institutions. And also in quality and performance improvement. We make up a lot of our hospital committees. We undergo these huge efforts in ACS or statewide verifications for trauma and burn centers. We play huge roles in research mentorship and education mentorship. And so there's a ton to do. And then in addition to that, we heard a little bit about, citizenship, like, I'm sick and tired of having 300 notes that I have to sign every single week. And I'm going to take Jennifer's tips on that. Coding, billing, we do our own coding and billing, the faculty educational modules that you have to do. It's a lot of work. So yes, we have to do all of those things. There's no question about that. You can say no to some, but you'll have to do some. But I want to get back to, given that we have all of those roles, and in addition, you have your personal goals. And if clinical service weeks are less than 26 per year, what is the expectation for the other weeks? We've been addressing that amongst all of our faculty. Are the faculty expected to be present in the hospital or not? Or are you at home just doing these things? And then how do you buy down your clinical service time or your effort? And finally, one last thought on financial ACS issues. We provide a huge positive contribution margin to the Department of Surgery. In the future, this may change. More surgical critical care billing is in the global surgical package. There is the question for each of our ACS faculty as to how much elective general surgery do they want to do. It also improves ACS contribution margin to the department. I think it's very important to achieve master surgeon level and really to improve surgical skills. But is it perceived as negative for ACS surgeon well-being? It's more clinical work. And what if it's above your expected clinical expectations and clinical time? How is that compensated? There is also the question that has come up here, I'm sure it's come up elsewhere, if we move to a national benchmark of a certain number of 12-hour shifts per month, 12 to 16 proposed, how will that impact ACS salary and compensation? General surgeons would be doing potentially more work, although, probably less intense. And they are compensated less than we are in acute care surgery. And then finally, my last word is, I really think we need to focus on investing in ACS faculty retention, less expensive than recruitment, and we need the older surgeons to help mentor our young faculty. So thanks again, Pat, for the opportunity to participate. I will get out of here.
Thank you so much. Those were 3 talks that I think really built on each other, and I do, echo that. I greatly appreciate the honesty, and I'm really excited that we're having these conversations and the transparency is increasing. So I want to, we have about 10 minutes left, and I dropped my email there in the chat if you have any questions after, but I'd like to hear from some of the attendees if you have any questions. These are 3 very excellent panelists, and I know they'll be honest in their responses. And if no one has questions, I certainly do.
There's one in the chat there, Pat, do you see it? Q&A says, when a group feels overworked and recognizes the need for an increase in FTE complement, any suggestions on how to help get the hospital to recognize this need?
I think that might be, anyone can answer this. I have many thoughts. Why don't we start with Dr. Hartwell? You unmuted, so why don't you start?
Yeah, the first thing I'll say is I'm not sure this can be super helpful, but I went through this when I was acting division chief in my prior institution. And one of the things that I was told by my C-suite was, well, your patient outcomes are fine. Like, I don't know why you guys need more help. Your patients are doing fine. And my response was, the patients will always do fine. If you're waiting for a bad outcome, it's not going to be on a patient. It's going to be on a provider who is at their wit's end. And God forbid that we ever have a surgeon end up in a situation of self-harm. So that was one of the things that I told my C-suite, and for whatever reason that did resonate with them, that we're burned out, and I provided some burnout data. I did a survey amongst our surgeons to assess burnout, and we were very high in our burnout rate. So that was some actionable data that I took to our C-suite to help inform the need for additional FTEs.
Dr. Napolitano, it sounds like you've had some of these discussions with your C-suite as well. I guess it's like kind of the crux of what is the value of ACS, and how do you make or advocate for them to see that value? The thing that comes up often is, we're in-house often, and if there's an emergency airway, that's usually us. But how do you measure that, and can you even?
Yeah, I don't think we can specifically measure it, but we've addressed this question specifically just in the last 6 months. The way we addressed it was to pull out your data, Pat, right? And then, sorry, there was still a desire to have additional information from other institutions that were like our academic centers, level 1 trauma centers, academic in focus. And that's why I did that personal reach out to, about 16 other centers, and really, again, found the data to be very similar to yours. And that's how then we were able to allow them to recognize that if your faculty is working too hard, they should get compensated. And that might be combat pay, that might be a clinical bonus, that might be, okay, we're going to commit to hiring this many more people, and in the meanwhile, we'll pay you this much per hour or per shift. And I think you need to negotiate that heavily.
Thank you for that. There's another question, limited to 26 weeks. What are the expectations for the other weeks? And depending on phenotype, just briefly while we wait for the panel, in our model, and this will vary depending on your model, our call is no longer done while you're on service during the weekdays. So no more post-call clinical work. And so in one of those, off weeks, that's when we do our, Monday night call, Thursday night call. And if you do a Monday, Thursday call, your week is ruined and is no longer an off week. And so we're now down to 1 week off a month to do all my administrative work. So I'm curious how the other panelists perceive that question.
That's a fantastic question. And I would just say that I do think it depends on phenotype. In other places where I've been, the people who are the most academically productive and writing the most papers have a reduced clinical load. And as someone who dabbles in research, I'm more than happy to take an extra call and let somebody else write all of the papers. So I do think it kind of depends. And our current expectation is you don't have to have your face in the office every day, but you have to get your work done. And we have some benchmarks about making sure our inbox is cleared out and, things like that. So if we're keeping up with our work, it doesn't matter whether we're in the office or not. And the other thing we learned from COVID was to value the hybrid work. So the vast majority of our meetings have a Zoom alternative, and that allows people to have kind of a flex day. And so if you can log on to M&M in the morning from home, you can still get your kids to school, or you can still, make lunch, but you are participating in the work of the day without taking the commute time. So that's been a real game changer for us.
I'm gonna come back to Dr. Guzman's Curtis question, because Dr. Buhavac, I want you to take Dr. Loomis's question. Advice for new fellows in their first job, balancing the new opportunity and taking on non-clinical, but also saying no and not overexerting themselves. I think you're well poised to answer that question.
What I will answer the question, and as I said, I would love to get the input from Dr. Hartwell and Dr. Napolitano about finding that middle ground between making sure that you are professionally taking care of yourselves while still contributing to the team. I think that some of these roles, I was a ICU director, I was a fellowship director, I was a trauma medical director. I think some of those things need to be taken on by more experienced faculty, because as I'm sure we'll hear in a moment, there are a lot of things that you need to navigate. And if you haven't had at least a few years under somebody's wing, trying to figure out how to, jump through the hoops that the ACS gives you in the various iterations of, the trauma standards, it's the gray book now, you're going to be taking on a lot more than you think. And those, I believe Dr. Hartwell referred to them as those white spaces, will tend to shrink down more and more, because you'll find yourself taking up more of your time trying to figure out how to do some of these things, rather than having somebody mentor you through that experience. So I would say, if you have the opportunity to take on a role as an assistant or an associate in some kind of position while you're gradually working your way up to it, that is a reasonable thing to expect as somebody between year 1 and 5. But taking on bigger roles, I think is it's more of a headache than something that's going to help you in the long term, but I may be wrong.
I think that's very good advice, and it's really exciting to see actually a lot of centers realizing that the TMD, the EGS service line director, the SICU medical director, like, that's a big job, and having assistance from, eager junior faculty and mentoring them to be that role in a year or two is really nice to see. The crux being that sometimes their time is not protected in a meaningful way, but it is it's not ultimately on you. Then you're not like the big boss yet, but you get that experience and leadership from someone who's willing to mentor you. I think that's really good advice. So we're going to go back here. Dr. Napolitano, you stuck on elective surgery, and it sounds like you believe that it should be part of the acute care surgeon's practice. And I know that's not universal, and we're going to skip over whether it should be or not. But how do you guys handle elective surgery in your model? Can you do it while you're on service? You got to do it on your off days? Does it count?
Yeah, so faculty determine whether they want to do it when they're on their ACS service or not. Again, we combine trauma and EGS into our service lines, right? So let's say you have an ostomy takedown and it seems like the volume that week is not in the 30s, then you might put an ostomy takedown and elective operation on that week. But if you're really doing elective surgery like abdominal wall reconstruction, ECF takedown, complex long operations, we don't put them on the service weeks. They're done separately. Right now, we don't have any additional compensation for that. So it's just done because you desire to do it. But many institutions, and again, in my 16 review, many institutions have compensation for that. And individuals will, get a 12-hour shift reduced or will get compensated at a certain monetary level for a certain case. And I think, again, we need to embrace that and recognize that clinical effort should be compensated when it is above and beyond what is expected. Although, again, I still strongly feel it's part of becoming a master surgeon.
Yeah, and to give a second example, this has been a challenge since I've been at MCW, in that elective surgery is somewhat expected, but a bit of an afterthought after the schedule's made. And it's typically discouraged to do on service lines because you're meant to take care of traumas when you're on trauma. You're not meant to be doing gallbladders and hernias necessarily. But to augment that discussion, if you want to incorporate robotics into your practice, you almost need an elective practice at least to learn, because it's really hard to learn otherwise. And we've encouraged, at least if you don't account for it currently, I recommend you prospectively try to account for it, because then you can at least go to leadership and say, here's how much our group does electively, and let's discuss either we're going to be compensated for that, or it's going to buy down our time otherwise and count as a shift. I think there's many ways you can do that. And Dr. Davis, thank you so much for attending. And I totally agree, socializing the flexible hybrid model. I'm curious, is there pushback from surgeons, leadership, both? I know we can't hear you or see you, but I agree. A white paper, I'm a big fan because it provides citable resources for some of our administration and demonstrating our value. And one of the better outcomes of COVID is Zoom M&M, so you can do some of that stuff you could otherwise have to be in attendance for. Leadership wants people in the office. Yes, that was my suspicion. And Dr. Napolitano, do you have any thoughts on, is someone expecting you all there all the time when they walk by your office, or is work from home a thing?
Yeah, the traditional approach is they expect us to be here. And I would say, particularly as we've been hiring junior faculty and they need mentors, like there are some clinical faculty here as part of our ACS division that are here in person. And then when someone needs help in the OR, they get called in, right? If you're at your lake house all the time when you're not on service, you're never here to help out. And so there is discussion, even from our own ACS faculty, about faculty doing different things. Like if everybody is just having personal time and family time and not contributing to education of our residents, fellows, and, onboarding our new faculty, and yet there are other people who are here all the time that are doing that, how does that get equalized? It's not, so I do think some is important, and I think expectations, maybe expectations and guidelines are important, and it'd be great to have a white paper.
Yeah, not, speaking from personal experience as a junior faculty, the amount of times I pop into someone's office to, either act as my therapist or ask them for help or advice, you can't beat that. And that's really hard to recreate virtually. And so there definitely is a middle ground there that is probably beneficial to the division as a whole, as Dr. Napolitano said. Okay, I think that's it. And, we're just a bit over time, so I appreciate people sticking around to answer questions and ask questions. I want to thank our panelists again. This was, I learned a lot. I always learn a lot listening to you all, and I hope our audience did. And I was serious. If you have any comments or questions, please do email me. Happy to chat. Thanks again, everyone.